we will start the cardiovascular system examination. Again, the time factor is very important because you get only 5 or 6 minutes for the total cardiovascular examination, and then the examiner will say the same thing, 2 minutes remaining. So you have to have a brisk way of examination. Again, I am stressing that inspection is very important. The patient should be relaxed. The neck muscles, the sternocleidomastoid, you make sure that they are relaxing, they are not taut, because if they are contracting, then you will miss all the DVP. Okay, so you have to make sure that it's relaxed, and then keep him in a reclining position and make sure patient is as comfortable as possible. It's not your comfort or convenience which we are giving importance. We are importance to the patient comfort. Okay, and then just come by the side of the foot end of the bed and then look for the dependent edema of the feet at the same time, and then you can see whether the jugular venous pressure and pulse, okay, is it the same, whether you can see very visible pulsations at the root of the neck, if there is any cyanosis or clubbing, and there is any thoracotomy scar. I could not see anything. Then I will come nearer to the patient and then look at the JVP. JVP means there are two facts. One, jugular venous pulsations and jugular venous pressure. These are the two things. So, you ideally speaking, you have to keep a pen or something, and then you can measure the upper level of the jugular venous pulse and then say this is a. We are not expecting you to do this during the 5 minutes examination because there is no time. If you can throw a light from the top and this shadow, you know this shadow, the shadow of this, that you can bring it down. When it comes to the normal person, the venous pulsation will be at the root of the neck. So you can see that shadow is moving. You understand? So you throw a light from top and bring it down like this. Okay? And when you start seeing the shadow moving, then that you know that there is the venous pulsation, venous pressure, or the level of the jugular venous pulse. So this you should always do. You see, you can see the shadow, no? Here, even at the root of the neck, I am not seeing any movement. So that means that the jugular venous pressure is not elevated. Okay? So that is one. And second thing, so you always carry a torch with you and look for this. And then you have to look at the pulsations. There are two types of pulses in the jugular venous system. That is, one is the A wave and the second is the V wave. Okay, the A wave is a flickering wave at the root of the neck, just a flickering wave. If there is a atrial dilatation or atrial pressure is high, you can get a flickering A wave, very prominent A wave. If you are seeing a venous pulsation all over the side of the neck, just medial to the sternocleidomastoid muscle, then you consider that it could be a CV wave of tricuspid regurgitation. Now I tell you what is the CV wave of the tricuspid regurgitation. All of you know that the venous pulsation, okay, if you trace it, it has got 3 peaks and 2 troughs. Okay, the first peak is the A wave, the second peak is the C wave, the third peak is the V wave, and there are 2 descents or troughs. That is, one is the X, the first one is the X and second is the Y. Okay. So A wave is due to during the late diastole. During the late part of the diastole, the atria will contract to empty as much as possible into the ventricle. That contraction during the late diastole produces the A wave, which is seen as a flickering movement at the root of the neck. Now comes the next wave, C wave. What is C wave? During the early systole, okay, after the diastole, the tricuspid valve will close, and before closure, there is an isovolumetric contraction of the right ventricle, which will trigger the closure of the tricuspid valve, and that closure increases transiently the pressure in the right atrium, which produces the C wave. You understand? Now, during the mid-systole, the valve is closed. Now there is a atrial relaxation with the descent of the atrial floor, which produces the X descent. Okay. So now coming the next peak, that is the V wave. During the late systole, what will happen? There is drainage of venous blood in both atria. That will build up the pressure in the atria, and that produces the V wave, the second peak, the third peak. Now, just last part of the diastole, there will be a passive filling of the blood from the atria to the ventricle. That produces a deceleration of the pressure in the atria. That produces the Y descent. Okay, so the A wave is due to the right atrial contraction during the late diastole. Now early systole, there is a isovolumetric contraction of the right ventricle, which produces the closure of the tricuspid valve. That produces the C wave. Now after that, the mid systole, there is a atrial relaxation and descent of the atrial floor, which produces the X descent, and then there is continued filling of the blood into the atria, which produces the next peak, the V wave. And now when there is the opening of the tricuspid occurs, there is a passive filling of the ventricle, and there is a deceleration of the pressure in the right atria. That produces the Y descent. These things happen when the tricuspid valve is competent. Suppose if there is an incompetent tricuspid valve, where the malcoaptation of the valve leaflets, there will be regurgitation of blood during the ventricular systole into the atria. So that will produce a loss of the X descent. That will lead to a loss of the X descent. So I told you the X descent is due to the atrial relaxation and the descent of the atrial floor. That will not happen because there is already regurgitation occurring even during the late systole. So that will produce loss of the X descent, and that will produce a fusion CV wave, which is seen as a very prominent palpable venous pulsation in the internal jugular vein, medial to the sternocleidomastoid muscle, and you will see that the whole of the side of the neck is pulsating. Sometimes you can see even the ear lobe is pulsating. So if you see such a venous pulsation, palpable, and all over the neck it is occupying by the medial side of the sternomastoid, then you know that this is a CV wave and the patient must be having a tricuspid regurgitation. So what I will do, I will come back and auscultate the left lower sternal edge of the sternum for a hollow systolic murmur which increases with inspiration, and then I have confirmed that this patient has got a tricuspid regurgitation. Then I will go back to the pulmonary area, auscultate over the pulmonary second sound whether it is accentuated, having a pulmonary hypertension, and at the same time I will carefully look for any early diastolic murmur of pulmonary incompetence. So that is the importance of the CV wave, which is seen as a venous pulsation at the root of the neck. So I will examine the pulse, I examine the pressure. Okay, so with the light I can see the venous pressure, and I can examine I will look for the pulsations. Now I will come back and see, I will try to localize the apical impulse. Okay, so the apical impulse, if it is normally placed in the fifth left intercostal space in the midclavicular line, I know that there is no left ventricular hypertrophy or there is no left ventricular volume overload. But if it is in the fifth left intercostal space in the midclavicular line, then I have to look for the character of the apical impulse. If I am not able to see in the anterior placed position, I will just lead him to the left, and then I will try to pinpoint the maximum cardiac impulse on the anterior chest wall with one finger and see whether there is any sustained heave or a heaving apical impulse, which gives me an idea that this patient has got a left ventricular hypertrophy. Suppose if the apical impulse or is the maximum point of cardiac impulse is displaced outwards and downwards, then I know this patient has got a volume overload. Even if there is a volume overload, I will just turn to the left and I will study the character of the apical impulse, whether there is any heaving apical impulse which is displaced outward and downwards. Then I know this patient has got the pressure overload as well as a volume overload. And one valvular lesion where there is a pressure overload and volume overload is aortic regurgitation. There are volume overload as well as a pressure overload. Then I will carefully auscultate for aortic regurgitation, because that's the importance of the apical impulse. So I have located the apical impulse and I have looked for the character of the apical impulse. Now I will keep my hand over the left sternal border for a parasternal heave, which is evidence of a right ventricular hypertrophy, or if there is a weak pulsation at the left upper left sternal border, then that is the left atrial enlargement. So I will look for that. Then I will look for any palpable sounds over the chest, a palpable thrill. Okay, this is finished. Then I will start examination. Okay, I will examine the mitral area first with the diaphragm of the stethoscope over the mitral area. I will assess the first sound and the second sound by keeping a hand on the carotid pulse. Okay, so I know along with the carotid pulse, which is synchronous, is the first sound, and after the carotid pulse, whichever I am hearing, is the second sound. Then I will inch, but before leaving that area, I will do the bell of the stethoscope and I will turn him to the left side and carefully look for a mid-diastolic rumble of mitral stenosis. Okay. Then I will come. Inching of auscultation is more important. I will come to the tricuspid area. Look for any hollow systolic murmur. If there is a hollow systolic murmur, I will ask him to take a deep breath and see whether it is an augmentation of the murmur. Then come to the secondary aortic area, auscultate here, ask him to sit up, bend forward, ask him to breathe out, hold the respiration for a while, seconds, and carefully look for any early diastolic murmur. Okay, and then keep him back, then go to the pulmonary area, look for the pulmonary second sound and any overt murmur. Then come to the aortic area. Okay, and then if there is a systolic murmur in the aortic area, keep over the carotid for any conduction to the carotids, and then finish. Then I will go to the back and again auscultate the lung bases for the crackles. So this is the only way. And after examining, suppose if I am hearing an ejection systolic murmur in the aortic area, I will say that I have examined this cardiovascular system of this gentleman who is not very comfortable with not dyspneic at rest, and he does not have any overt findings of cardiac failure. His jugular venous pressure is normal and there are no particular pulsations I could see over the jugular, internal jugular venous system. On Oscar, the apical impulse seems to be in the fifth left intercostal space, and auscultation, the first sound is normally heard and the second sound is also normally heard, but I can hear an ejection systolic murmur of grade 4 by 5 or 3 by 5, which is even conducted to the carotids in the aortic area as well as in the secondary aortic area. So I feel this patient has got an evidence of aortic stenosis. Then the examiner can ask you, what is the severity of the aortic stenosis in the clinical examination. So here you have to look for 2-3 things to assess the severity of the aortic stenosis, because aortic stenosis is a common valvular disease kept in the exam, because it is the commonest valvular disease in the developed countries actually. Okay, so they will ask you how will you assess the severity of the aortic stenosis. One is a delayed carotid upstroke. delayed palpable carotid upstroke. You keep the thumb over the carotid and time with the first sound. You can say that there is a delayed carotid upstroke because there is an obstruction to the flow into the left ventricle because of the obstruction. So there will be a delay in the carotid upstroke, that one. Second, a late peaking systolic murmur. It's not an ejection systolic murmur which starts after the second sound, but you can hear after the first sound, but it is a late peaking systolic murmur. And the third one is a soft aortic second sound. These three will give an idea that there is a moderately severe aortic stenosis. That means the aortic stenosis, that the maximum flow velocity by echocardiography is more than 4 meters per square meter, 4 meter per square meter of the body surface area, and the trans-aortic pressure gradient is more than 40 millimeters of mercury. So it is a severe aortic stenosis. And if this patient is symptomatic, I will send him for the valve replacement or valve repair or whatever it may be. Okay. So that is what aortic stenosis. Now the etiology of the aortic stenosis, they can ask you. The commonest etiology in this era is the calcific aortic stenosis in a congenital bicuspid aortic valve. That is the commonest cause. The second one is the degenerative change in the trileaflet aortic valve. And the third one is the rheumatic. And the fourth one is the congenital, where is only a fusion of the aortic valve leaflets. There is no abnormality, only the fusion of the valve leaflets. So these are the four etiologies you have to think of the aortic stenosis. One is a calcific aortic stenosis in a congenital bicuspid valve. Second, degenerative or a aortic stenosis in a trileaflet valve. And the third one is the rheumatic, and the fourth one is congenital. Now rheumatic aortic stenosis isolated is very rare. 99% of the cases, the rheumatic valvular disease will be combined. Mitral valve plus aortic valve. And most of the time the aortic valve, there will be aortic stenosis and aortic regurgitation. Okay. So these are the things you should remember regarding aortic stenosis. Whenever the patient is symptomatic, you will refer him for valve replacement, because otherwise the mortality is very high. Okay. Now, if it is an aortic regurgitation, then you have to assess the severity in the clinical examination. If you hear a loud decrescent or diastolic murmur in the secondary aortic area, one. Second, with a bounding peripheral pulses, if there is a wide pulse pressure, and if there is a third heart sound, I know this patient has got moderately severe aortic regurgitation. Okay. So a loud, here, this is the only valvulation where the loudness of the murmur is proportional to the degree of the valvulation. All the other cases you can get a very loud murmur, but there may not be, that loudness will not be correlating with the severity of the valvulation. But in aortic regurgitation, if there is a very loud decrescent or diastolic murmur, and if there are bounding peripheral pulses, especially at the root of the neck, and there is a wide pulse pressure, and if there is a third heart sound, and if the apical impulse is displaced outward and downward, then this is moderately severe aortic regurgitation. He also needs to be referred to the thoracic surgeon for valve replacement or valve repair, whatever it may be. Okay. Now the etiology of the aortic regurgitation, again, you can think of. One is a degenerative change in the bicuspid aortic valve producing aortic regurgitation, or it could be what? It could be a rheumatic, okay, or it could be infective endocarditis. These are the common causes of aortic regurgitation. And then aortic root dilatation and the annular dilatation. Aortic root dilatation also can lead to regurgitation. These are the common causes of aortic regurgitation. Now mitral stenosis, whenever you are getting a mitral stenosis, you have to very carefully auscultate. There are two etiologies. One, it is rheumatic, or it's a calcific mitral valve which produces mechanical obstruction to the mitral flow, producing a diastolic murmur. These are only two possibilities. Mitral regurgitation, the commonest is a degenerative mitral regurgitation. Okay, that is the functional abnormality underlying this degenerative disease is a mitral valve prolapse. That is one. Second, there can be annular dilatation. So that can produce a mitral regurgitation. Or it can be a congenital mitral regurgitation with a cleft in the anterior leaflet. Or it can be a rheumatic mitral regurgitation. Or it could be a ventricular dysfunction producing mitral regurgitation, either ischemic or non-ischemic. These are the causes of mitral regurgitation, and you can get in the exam mitral regurgitation because there are so many patients with their ventricular dysfunction secondary to coronary artery disease with either ischemic or non-ischemic ventricular dysfunction having mitral regurgitation, so you can get a case. And there will be a pansystolic murmur. The difference between a pansystolic murmur and ejection systolic murmur is the pansystolic murmur stands for the first sound and extends to the second sound. Okay, the whole systole is occupied. Whereas ejection systolic murmur stands with the first sound, but the second sound is clearly heard because it stops early. But as the degree of stenosis, aortic stenosis increases, the murmur becomes prolonged and it can become even hollow systolic murmur. So that then you have to correlate the findings. Okay. So left ventricular hypertrophy, left ventricular dilatation, that can be found out by the apical impulse examination. So and then the valve, replaced valves you can get, prosthetic valve. In a mitral prosthetic valve, if it is a mechanical valve, usually you hear the sound very audibly in the mitral area and the lower sternal area. Whereas if the click is best heard in the base of the heart, then that goes in for the aortic valve. But this can be timed with the carotid pulse. So you just keep your thumb over the carotid pulse and the auscultate. If the click is simultaneous with the pulse, that goes in favor of the first sound. If it is after that, then you know it is the aortic valve which is replaced. Okay, so sometimes both can be replaced. Aortic and mitral valve can be replaced. Then you have to be very careful that you are hearing a click very clearly in the mitral area, and that corresponds to the carotid pulse. And then you are coming to the base, again you are hearing another click which is hearing after the carotid pulse. So you know that both valves are replaced. And carefully look for the thoracotomy scar. Nowadays the scar is very small. Sometimes you miss the scar because it is underneath the nipple area, and it will be covered by the hair which the men have. So you have to be very careful looking for the scar. And then the another question which we can ask you is, what is the role of bacterial endocarditis prophylaxis in these cases? Now according to the latest guideline, there is, unless there is a prosthetic valve, if the patient has got a native valve lesion, there is no role for bacterial endocarditis prophylaxis unless there is a history of bacterial endocarditis in the past. But if he has a prosthetic valve, most of the time you give the bacterial endocarditis prophylaxis. So this is the two indications for bacterial endocarditis prophylaxis in the valvular lesions. So you have any doubts?
This presentation also.
So again the presentation, you can say, okay, suppose if this patient has got a pansystolic murmur in the mitral area. So I will say, okay, I have examined this gentleman's cardiovascular system. He is not in overt cardiac failure. The jugular venous pulse and pressure seems to be normal. The apical impulse is in the 5th left intercostal space or 6th left intercostal space, and it is a bit forcible apical impulse. And on auscultation, I could hear the first sound is soft and there is a pansystolic murmur, and followed by the normal second sound with the pulmonary component of the second sound seems to be a bit accentuated. So I think this patient has got evidence of a mitral regurgitation. And then the examiner asks you what are the differential diagnoses. So other differential diagnosis could be a tricuspid regurgitation or a ventricular septal defect, where also we can get a pansystolic murmur. But here the murmur is conducted to the axilla and also not increasing with the respiration, and there are no other signs of tricuspid regurgitation like the CV wave, giant V wave venous pulsation. So I think this patient has got a mitral regurgitation. Okay. So if it is an aortic stenosis, you can say, okay, I examine this patient and the first sound is normally heard. There is an ejection systolic murmur in the aortic area which is conducted to the carotids, and the second sound, the aortic component seems to be soft, and I can also feel a delayed carotid upstroke. Okay, and then I think this patient has got moderately severe aortic stenosis. If it is a mitral valve click, then I will say, okay, examine the gentleman's cardiovascular system. He is not in overt cardiac failure and the JVP is so and so. And I auscultated. The first sound seems to be replaced by a metallic click, and the second sound is normally heard. There is no murmur. So I think this patient has got a function mitral valve metallic prosthesis. Okay. So if there is a paravalvular regurgitation and a murmur is there, then you can say, okay, there is a regurgitant murmur also I am heard. Probably he must be having a paravalvular regurgitation. Okay. Anything else?
Functional status and feature of infective endocarditis.
Pardon?
Functional status and
You can say, if along with the negative findings, you can say, I am not seeing any findings suggestive of a bacterial endocarditis. That's okay. That's a relevant finding, negative finding, which you can say along with the cardiovascular system examination findings. There is no harm in doing that. But first thing, positive signs, and then you can say the negative, relevant and negative findings.
if there is two pathology, that means double valve lesion.
Pardon?
If there is double valve lesion, I'm not confident about the other, or the dominant one is the other one. What
You see, we usually we are not giving much importance to that in the clinic. If you pick up, so for example, if the patient has got an aortic stenosis and aortic regurgitation, okay, and if the patient, the apical impulse is a sustained heave and is in the fifth left intercostal space without any displacement outwards, and at the same time there is a regurgitant murmur and the bounding pulses are not very well observed, then I will say, okay, I feel this patient has got a predominant aortic stenosis plus an aortic regurgitation. But if you are not able to say that, because the patient has got a bounding pulse, the patient has got a wide pulse pressure, the patient has also displacement of the apical impulse outwards and downwards, and at the same time there is a late peaking systolic murmur and there is a very loud decrescent or diastolic murmur, then I will say I am not able to say which is dominant because both are equally heard. So I think the patient has got a codominant lesion involving the aortic valve, aortic stenosis and aortic regurgitation. We are not going to fail you even if you miss, and if you say, okay, this one is dominant, this one is dominant, we will not fail you. Okay, the clinical findings are most important. If you miss the clinical signs completely, then even if the clinical examination technique is good, probably you may fail. So you have to be very careful. Anything else?
If I picked one, I consider to omit the other because I'm not confident with
Okay.
that time I will fail or?
No, you will get a borderline. Suppose if the patient has got two lesions in aortic valve or aortic regurgitation plus mitral stenosis, and you have missed the mitral stenosis, you pick up the aortic regurgitation, you will get a borderline. So we will say that this patient has two lesions, but if he picks up one, then he will get a borderline. If he picks up two, then he will get a pass, clear pass. But even if you have a doubt, you can say, okay, I am also hearing a mid-diastole crumble in the mitral area, which is best heard in the left lateral position and in the expiration. So I feel this patient may be having a mitral stenosis also along with aortic regurgitation. You will pass. But the dominant one and the confident one you first present, and then say there is a suggestion of this. Okay, then practice, practice and practice. Yes. Wish you all the best. Thank you.